I'm Dr. Gregory Albert, board-certified plastic surgeon. Let's discuss male breast reduction. Gynecomastia is breast tissue in men. Men with this condition will avoid activities such as swimming, exercise, and sex to avoid exposing their chest. With a rather simple procedure, men feel liberated. They're able to take off their shirts and wear clothes more comfortably.
Dr. Albert offers complimentary consultations. Visit our office in Delray Beach. Call 877-3-ALBERT today.
I'm Dr. Kenneth Levine. Welcome back to Health Talk, seen on WEYW19.com and on UVerse 19 throughout South Florida. I'm here with Dr. David Robinson. We started before talking about mastectomies. There's a tremendous emotional toll it takes on the woman and their families. Do you ever recommend a single mastectomy for a patient?
Sure. It's a difficult decision always to decide what to do for a woman. I almost always recommend considering that if the woman's going to have a mastectomy. I have a number of people who've come back and said, you know, I'm just not quite as happy having had the normal contralateral breast removed. And now these are people who don't have a significant risk of developing a contralateral cancer. The risk is about 1 to 1.5% per year. So at 10 years, it's about 14–15%. And you can figure out what the rest of the population would do. Those people, if they're watched carefully, can probably have a single mastectomy, and they're usually pretty satisfied with that.
Now, you mentioned bringing in a plastic surgeon to do the reconstruction. You're not involved with that in your practice?
No. It became kind of an interesting prohibitive factor when I was on faculty in Miami, and that the chairman, Dr. Zeppa, suggested that the malpractice insurance would be enormous if we did both. So we do the extirpative portion, and that's the way most of the people who deal with breast disease do it. There are plastic surgeons who really are very good and specialize in breast reconstruction. And so at this point, we've changed a little bit from what we used to do. We now have skin salvage mastectomy. We take the breast out, leaving the skin in place, oftentimes the nipple in place, and it seems to be relatively safe. And then they come along with a tissue expander behind, and it has a much more natural look.
Is that done at the same surgery, or is it later on?
If it's skin salvage, it's almost always done at the same time. If we have a patient with a very large breast cancer and she needs a standard mastectomy in which we take the nipple-areolar complex, that could be done at the same time, or it could be done later.
What's the relationship between ovarian, uterine cancer, and breast cancer?
In the BRCA1 and BRCA2 patients, the relationship is a genetic one. It's a mutagen. And interestingly enough, it's not just the ovary, but it's also the tubes that connect up, the Salping tubes that connect the ovary back to the uterus. And so those are often taken now, but in most breast cancers that are sporadic, there is no effective relationship.
I got you. When you meet with a patient, and you counsel them, do they know ahead of time if they're going to need pre-op? I would imagine they know if they're going to need pre-op chemo. How about post-op? Do they always know that?
Well, when I sit down with somebody, if the woman comes in with a breast cancer that's over 4 centimeters, or about 2.5 centimeters to the inch, so maybe about 1.5 inches, and we can measure it, she might be a candidate for preoperative chemotherapy. In the event that it's a smaller tumor and we can perform a lumpectomy or a mastectomy followed by radiation therapy, then we talk about postoperative chemotherapy. And that, it lasts about 4 to 6 months usually in the hands of a medical oncologist.
I have about a dozen friends that I know who've gone through some type of breast cancer and surgery or chemo or both. I don't recall that as a younger person, or as a young man, or as a child having that issue. Is this more frequent today, or is it better diagnosed? What's the situation?
There have been so many people involved in prospective trials that it's now been well proven that there's a benefit to providing this for people at risk. You can calculate it out. If your risk were perhaps 10%, and you had a 90% risk of doing well, giving you adjuvant chemotherapy probably is going to only help 1.5% of those people, and it's not worth doing. If your risk is 50%, since there's about a 15 to 20% benefit, then it is worth doing, and most of the people at that point move ahead to do it. It's determined in part by lymph node involvement, right, and by some other factors as well.
Okay, and you determine that at the time of surgery. We're going to get back to that in just a minute. It's Dr. Kenny Levine with Health Talk. We'll see you in a moment. Thank you.